Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
Okay, we're good to go then. Okay, and I'm happy to report I've been skating. By that, I mean like 3 sessions since the last time we spoke, and I successfully left the tennis court.
Wow.
That's the last episode. Just once. We have the street that's pretty big near Harvard that opens up for foot traffic, pedestrians, and skaters. So I wandered out there and I survived. No falls. A little bumpy on the asphalt, but we did survive. No, what did he call it? No foosh injuries. So we're ready to go for this episode, basically.
You're not bombing down the hills yet?
Oh my gosh, yeah, definitely not. All right, you will bomb down this case, though. I think you're going to like this one. I really enjoyed this case. It's one of the last cases in residency I saw that was really a DX atypia type of episode. And it was on the general service, and the patient is a woman in her 60s who has obesity with a Roux-en-Y gastric bypass, early stage CKD, radiographic emphysema, and recurrent VTE. She's currently on Eliquis and has an IVC filter. And she basically came with altered mental status. And this is all from the reports of the chart. I met her basically in the middle of her hospitalization. But according to her son, over the course of 48 hours, he noted that she had increasing diffuse body, quote, tremor, unsteady gaits, and memory lapses. She was also increasingly weak throughout her body. And according to him, she did not have any clear preceding symptoms prior to this, like no sore throat, no cough, no fevers, no chills, no shortness of breath, chest pain, abdominal pain, or GI symptoms. Her presenting vitals, no fever, heart rate in the hundreds, pressures of 130/80s, and SATs of 94% on room air. And then on the initial exam documentation, she had faint right-sided posterior crackles, no murmurs, normal JVP, normal abdominal exam, and only trace right lower extremity edema. And a CT of her head for this, altered mental status just showed a small subdural hematoma, no concerning kind of related findings to that. And then her initial labs, I'll read out systematically because she has quite a few derangements. So she had a creatinine of 5.5 from a baseline of 1.5, a BUN of 94, a sodium of 133, a K of 5.9, chloride of 101, bicarb of 16 with a gap of 16, glucose of 131, calcium of 7.4, mag of 2.1, phos of 6.4, AST of 39, ALT of 27, total bili of 0.4, an alk phos of 1,100, and normal ammonia. And the CBC showed a white count of 12.8 with 84% neutrophils, stable hemoglobin at 11.2, and normal platelets. So I basically just presented you a ton of data because I was curious if you could summarize kind of everything you just saw there. And I'm just curious kind of how you sift through all that noise. Cause when you get a patient like that, a lot of red numbers and epic. So just in the context of the patient's kind of like generalized weakness, tremors, and altered mental status, is there like a way to kind of like summarize all those findings and just how do you be thinking through that?
It's a lot to summarize. I don't know if I can get it all into one box, but I'll try. So we have, how old was she again? 60?
Oh yeah, she's in her 60s.
Okay, so we have elderly, late middle age woman who sounds like she was overall relatively healthy and had acute altered mental status with changes with sounds like some other nonspecific neurologic findings as well, with tremors, and it's found to have a severe AKI on mild CKD with a lot of the metabolic derangements you'd expect for really renal failure. And then sort of this ALK phos, which is sort of so elevated that you can't ignore it. And I don't. That's kind of what I'll just leave it at there. I'd say that generates a differential, but
yeah, and Mike, I'll just stop you there and like put you in the headspace of. I mean, I wasn't the admitting doctor, but she, as you appropriately said, she came in with like a very whopping AKI, so they were like appropriately focusing on that. So we'll definitely get back to that ALK phos. So just I guess zoning in on the AKI, just like bread and butter medicine here. Just like what tests would you be doing for her first on kind of your initial evaluation of her?
So I think the first thing is just her vitals, right? Which you already mentioned. She was stable. Unless I'm forgetting that, blood pressure was okay, and yeah, I think actually the first test, like I said, with AKI is just understanding the context within which that AKI is presenting. So it sounds like here she's altered. Is it possible that she had poor PO intake over a period of time? It is, right? So could there be dehydration? It's possible. Unlikely to give you this degree of an AKI unless it's sort of that's a hit on top of something else that's going on. And then even before any of the urine stuff, just taking a look at the labs and the other, presenting, does this person have obvious signs of infection, sepsis? Because even if you're not hypotensive, you can still have, relatively depleted intravascular volume, right? And then are there any obvious drug exposures on history that this person had? Someone who was fine, took a drug, and then now they're, prescribed or illicit, and then is presenting with this. So I think that just kind of understanding the context within which this person's presenting with an AKI is the first step. And then, you have all the studies that we learn in med school. I think the one that is the most helpful is the UA, because it's like the poor man's renal biopsy. So you're going to be able to see what's coming out of the glomerulus in a perfect scenario. So, is there blood? If there is blood, are there casts of that blood? Are there white blood cells? If there's white blood cells, are there casts of those? Is there signs of infection in terms of that? Although you have to interpret that carefully here. And then also, if there's signs of blood on the dip, but then no RBCs, is there something like rhabdo going on? So it gives you a lot of information about what's going on between the glomerulus and the collecting duct that, and then also, out, through the ureters and the bladder, right? Blood, and leukocytes and leukocyte esterase. So those things I think are helpful. And then the FENA, it's helpful, I think, in a specific context. So really the way the FENA was validated was in someone where you're pretty sure they've got a prerenal mechanism, and then you're trying to determine whether or not they're have still in that prerenal window, or they've now kind of progressed into ATN. And I think that that's where it's the most helpful, is in knowing, is this person going to be fluid responsive or not, because this person's still in a prerenal physiology versus someone who's already, for lack of a better word, infarcted their tubules. So I think that that's helpful in that regard. You have to remember that the whole premise of the FENA is that this tubules are managing sodium appropriately, right? That's the assumption. So that when you're volume down or have vascular congestion, when you don't have good flow across the glomerulus, then the kidneys will appropriately retain sodium. And so her CKD doesn't sound terrible, but in someone who, as your baseline kidney function worsens, then it's just not going to handle sodium quite the same way. And then you throw in people who are on diuretics. And so that can kind of throw things off. And I think the FeNA is the most helpful when you're pretty sure it's pre-renal and you're trying to confirm that. And I'd say it's the most helpful in the extremes, like a FeNA of 0.95. I don't know, a FeNA of 0.01 or something. That's pretty clear. But you could also just look at the urine sodium in that case. So I think those are the big things there. And then if you feel comfortable focusing, then taking a look at the bladder, taking a look for hydro. Oftentimes, renal ultrasound is part of the order set. But just remember that you need generally bilateral hydronephrosis to cause an AKI on labs. So it's usually going to be the bladder, and BPH is going to be pretty classic. Not going to be the case in this case. And then another really classic one is someone who has a Foley and the Foley gets kinked. And then all of a sudden they get an AKI and everyone's focused on something else like heart failure, the reason they have the Foley, and sepsis. And then it just turns out that the Foley is kinked. So in the ICU, that's like a classic thing to just make sure you don't forget. So I think I'll stop there. So I'm going to say UA, urine lights, and an ultrasound of some sort, whether you do it or whether a radiologist does it.
Oh, that's awesome, Mike. I think that what you show is that the history could be so helpful and the exam could be so helpful in terms of needing to even like bypass a lot of this workup too. Like if you have that history of like severe dehydration or heart failure, it's like, okay, you're just going to kind of go for that underlying cause too, and kind of not even worry about, any sort of further workup. I feel like oftentimes in real life, we talk about these studies, but if everything kind of fits and you do your empiric therapy, you can, forego kind of all these nitty gritty tests where it is like important for us to know the details so we know how to interpret it all. But I'm finding in my practice, I'm often just treating these things and seeing where they land. So I'll tell you what they got and get your thoughts after. So they got the UA. It showed no red cells, no white cells, and 2+ protein. But they did get a spot urine protein and creatinine, and it was only 0.72, so just like mildly elevated. And nephrology is consulted, and they spin the urine, and that shows rare granular casts. And then regarding her CKD, her A1C for many years has been normal. She has fairly controlled blood pressures, but does have a history of hypertension. She follows hematology for her recurrent VTE events, and they've since, for that, actually like paraprotein workups that were notable for elevated kappa and lambda light chains, but a normal ratio for CKD, so basically normal. And the only monoclonal protein that they detected has been in a urine sample, and that paraprotein was a free kappa light chain with a possible accompanying IgG heavy chain. So it's really like a plus or minus on that. And then they got a renal ultrasound. It showed no hydronephrosis and just a slight decrease in the size of the kidneys, consistent with her known CKD without an endpoint diagnosis. So I guess just like being authentic here, kind of the purpose of this space. Where would your head be at with this AKI at this time point? It's like, it's pretty bad. Not much protein in there, no glomerular signature. She came in like altered, confused, just like, I'm just curious where you'd be going next, since that's kind of like the center of the case so far, ignoring that alk phos, which we'll get to.
Yeah. What's challenging here is that there's not a lot of help from any of the studies that we just talked about. Did she have a urine sodium? I forget if you mentioned that.
Oh yeah, no urine light. Sorry, Mike.
No worries. I sort of already mentioned that I didn't think they were terribly helpful, so I shouldn't expect them to be there. I think that, I think that we don't have a lot of information for the stuff that's coming out of the kidney, either the blood that's coming out in our labs or the urine that's coming out. And the proteinuria, hard to say if that's acute or just chronic as a result of, poorly controlled hypertension or something else that may become important later. But isn't obvious. And with the alk phos being so high, it's helpful to hear that she's actually had someone think about paraproteinemia as something that would cause bone lesions and cause an alk phos to be high, and then also cause an AKI. So that's helpful to know that's not, at least that's been thought about in the past. I think that what I'm sort of pulling together here right now is that you have someone who is altered and has severe AKI. And whenever I hear those two things together, common things being common, as long as she isn't teetering on pulmonary edema, I kind of just want to give her, a fluid challenge and see what happens, and use that bolus as sort of a diagnostic and therapeutic intervention. Because again, altered mental status begets poor PO and dehydration, and then dehydration begets altered mental status. And I think my mind sort of goes back to the history again, and I want to know, is there some sort of exposure that she's had that may have led to some sort of intoxication or toxicity? And I forget if you mentioned what medications she's on.
Yeah, she. I feel like I give that in a later aliquot. I'll just say right now, though, when I meet her, her altered mental status is resolved. It'll be helpful here just to tell you no recent changes to medications and no new supplements, nothing over the counter, nothing from like a herbalist. I don't know what you call people. What is it? Homeopaths? Nothing like that. And you're right. Just the striking thing about this in retrospect, when we did talk to her, was really like before this kind of like generalized weakness and just like being off of her usual self, like they were pretty adamant, like nothing kind of like led up to this, which is why it was such a tough story with the positive UA, kind of why I'm bringing it here, because it is, it's not really clear at this time what's going on.
Okay. So that's helpful. And actually, I think I may have jumped the gun a little bit on history. So she was altered and now she's no longer altered. Is that?
So I'm just being very confusing, Mike, because I'm like jumping time points. I met her kind of like after the AKI has been resuscitated. She like went to the step down units and was like very altered, and then I got this additional history I just provided you kind of like after she got better. So I just gave you a hint. Her AKI does get better with fluids. Is basically what ends up happening, and I think that that's okay to give you, because that's where I like do intercept her, but it does it does beg the question of what happened, and what are your thoughts? So I'll just say she got a ton of fluids. They treated her for like basically pneumonia, and I'll give you some more imaging in a sec, but that's kind of the AKI progression.
Okay So she probably had some level of toxic metabolic encephalopathy, and then maybe sepsis or something. But that is kind of the other test you can do, is give fluids and see what happens, if you think that's a safe thing to do. And usually it is. So that's helpful. So there was at least some level of like hemodynamic pre-renal physiology to her AKI if it resolved with fluids, right? So that's helpful to know. So I guess the question I would have next would be, we have a renal ultrasound. I'm kind of wondering if they're. So I guess that it sounds like she got treated for pneumonia, so there was some chest imaging of some sort.
And I'll just this is a very like it's a very confusing case. So I'll bring up the chest imaging. The chest CT, I'll give you more findings in a second. It did show some sort of like focal lung infiltrate, so they ended up like treating her for pneumonia. And by the way, if this is like if these are all of your thoughts, it's totally cool. We could just like keep going too, because this is real life and how we were. I mean, I didn't see her at that time point, but I would have been in your same headspace here. It really, without a slam dunk kind of history for how the AKI kind of progressed. Exact same thoughts. thinking like ATN at this point, but is there something more? We can get back to it. But yeah, any other thoughts? And then I could kind of take us to a different space.
So I think at this point, I would probably, I don't exactly know in terms of the AKI. Like it sounds like there was something pre-renal. Maybe there was ATN already developed and they gave fluids and it's gotten better. Did it get all the way better?
Mostly, yeah. If we skip forward, by the time I meet here, it is like, yeah, it gets mostly better.
Okay. And the intervention was fluid. That's like what she got better from.
Yeah, the intervention was fluid, antibiotics, no concern for obstruction. And then I meet her, and she's like fully oriented now and doing much better. Yeah.
Okay. All right. So then maybe we don't exactly know why she was hemodynamic physiology pre-renal, but it sounds like she definitely was, if that's the intervention that made the difference. And I'm guessing that sepsis, if we if that's what we thought was, that's what caused her to vasodilate maybe and give her this AKI. That was pretty impressive. Did she get dialyzed or did she do okay? Like those things got better with just fluid?
Yeah, she just got better. She got like a ton of fluid, and yeah, she just got better. Thankfully, she didn't need dialysis. But yeah, like examining it just at this time points, I mean, the most likely thing, and we learned this in residency, is really like ATN in the hospitalized patient for patients who are sick as being kind of the most common reason for AKI. So at this time point, it definitely seems that's the case. And I'm going to kind of bring us to a different space now with this aliquot. Ignore the AKI for a second, and then at the very end, we're going to kind of tie it all together and see if it can play in to the AKI. So ignore the AKI. Here's some other very interesting information, and this is how the case got very interesting. So the initial chest X-ray, as I kind of already pulled up, it showed like a patchy right lower lobe alveolar infiltrate. And then due to concern for potential sepsis in light of her initial disorientation, she received a pan scan without contrast, and it showed the patchy ground glass over the right lung, normal abdomen, and a few bone findings. For the lung findings, she was treated with 5 days of cap coverage. The bone findings included, quote, permeative pattern of the L4 vertebrae concerning for possible osteomyelitis, end quote, as well as a diffuse bone disease described as, quote, osteodystrophy, end quote. As her AKI was resuscitated with these fluids, her calcium remained quite low, and it even decreased to 6.0. And this was with only mildly low serum albumin, confirming true hypocalcemia. And this is if you believe in the correction formula, that's actually become quite controversial for calcium correction. There's a good things we do for no reason article on that was published 1 or 2 years ago. But she remained asymptomatic through the low calcium, so nothing like seizures. And then during the low calcium measurements, her FOS improved from 6.4, from her AKI initially. The FOS improved to normal as the AKI stabilized. And basically, despite the normal FOS, she was still quite hypocalcemic in the 6.0 range. Nephrology was consulted and following, and they wanted to reassess her kidney CKD picture. So they sent a 25 hydroxy vitamin D, and that was sent and actually came back undetectably low. And a PTH was 1800 with the upper limit being 65, so very, very high. And then looking at some of her old labs related to her Roux-en-Y gastric bypass, she actually had an undetectable 25 hydroxy vitamin D level 10 years prior, undetectable B1 several years ago, low vitamin E several years ago, and a high methylmalonic acid. And this was like, not just for context of how we kind of arrived here, that was like not the forefront in her one-liner. Her one-liner was like compensated alcohol cirrhosis, radiographic emphysema. But when we saw that the vitamin D level was undetectably low, I just typed in the EPIC results vitamin and see what popped up. And I went through all these nutritional labs and all these things were low. So low vitamin E and then the high methylmalonic. So she then lands on our service and has her improved mental status. And she confirmed she isn't taking any of the supplements. Her only concern is scattered non-specific pain that's predominantly in the legs. But on exam, we palpate her tibias and find that they're diffusely tender on bone palpation, and there's no tenderness along the muscles or soft tissues. So What is your assessment of the patient's hypocalcemia? And I can provide any of those numbers again. I know this is basically a numbers episode. I'm just throwing you a bunch of numbers. But what do you think about the hypocalcemia?
I have to be honest that I just sort of ignored that because I assumed that she had something, albumin was super low and she's really inflamed, and it didn't even register. Like the calcium, I heard it and I was like, okay, we'll come back to that later. So it's interesting that it's gotten worse. This is not my strong suit, Andrew. The calcium metabolism, but let's give it a shot. So, if you remember nothing else, just remember to check the PTH, and then everything else will hopefully flow from there. So, an elevated PTH means, I guess, a couple things. So, in renal failure with hyperphosphatemia, they run together. So that's what I think when she came in, what I think I would be thinking of. And then, of course, an elevated PTH, especially with a normal or low phosphate, oftentimes, vitamin D deficiency, severe vitamin D deficiency. And then a low PTH, then you're thinking about something like hypoparathyroidism. Low magnesium, I believe, also can do that. So really just remember, is the parathyroid the offender or is it the responder? So high PTH, it's a responder. Low PTH, it's the driver in hypocalcemia. What I don't know how to reconcile is the bone lesions with the hypocalcemia. Hypercalcemia and bone lesions makes you think of myeloma, especially if someone has an AKI. I can't remember if it was like a heavier light chain, but I remember she had some sort of abnormal SPEP, I believe you told me. But yeah, I don't know how to reconcile those things. Not at this time, at least.
Yeah, no, I mean, it's not we don't, I haven't had a lot of severe hypocalcemia cases I had to like thoughtfully think through. So nothing jumped out at me off the bat here. So I'll just say that. And okay, so another aspect of this, the alk phos being like 1100, and this radiographic bone finding of possible osteomyelitis. I know you mentioned just now, like Mets, but anytime you see a quote possible osteomyelitis on a bone scan, like on an overnight presentation, you have to talk about it. So we were like thinking about this. What are we gonna do? Like, is this someone you would go down that like biopsy path for like rule out osteomyelitis? I'm just curious. We were trying to put all of our heads together and try and figure that out.
So I'm sorry I keep going back. She wasn't febrile, right?
Initially I didn't, at least not that I wrote down. And again, I didn't like see her at time point 0, but yeah, I didn't, no like super high fevers. No. Just a leukocytosis with a neutrophilic predominance. And I do remember by the time I met her, that's like better.
Yeah. Okay. So sounds like that's like found an opacity. She was very confused. Maybe sepsis, but not something clear. And then she had, her CBC looked like she was infected. So, okay. So she didn't come in like screaming sepsis, which you'd expect if someone had acute vertebral osteo. They're usually pretty sick. And I guess she was, but not in the way I would expect. And you mentioned, I think, the social history. There's no obvious use of IV drugs. There's no prior history of valvular disease, and then something that would have seeded that, dental cleaning or something. No. Yeah, I think what I would want to do first is I'd want to take a picture of the legs, because she has findings in the spine, in the bones of the spine. She has 2 findings in her labs that would be concerning for something, a bone pathology, right? Her alk phos is really high, that's any sort of bone pathology disease that's destroying the bone, right? It will cause an elevated alk phos. And then hypocalcemia, you can get hypercalcemia, but you also get hypocalcemia with bone diseases. And so I think the reason I would go looking at the legs is because I'd want to see if there's a lesion there. One, because maybe the radiographic findings there are more pathognomonic for something else. It would be very weird to have osteo in multiple bones in the tibia, you said it was, and then also in the back. You need some sort of systemic infection to do that. And I wouldn't expect that she would have gotten better with 5 days of cap coverage. And so I think that I'd probably get a picture of a CT scan, bone scan, I don't know, of the tibia, and see if what does that look like? And then also possibly then that's an easier biopsy site than the spine. If you do need to get a biopsy and it looks like it's a similar type of lesion, then you can go for the tibia, rather than the vertebra.
Yeah. I think what you were just doing there is very similar to what my brain was trying to do when we, transfer this patient from the step down unit. It's like really try to like justify the whole osteomyelitis thing. And I really like the questions about like question of IV drug use, like risk factors, like is this the right person to get osteomyelitis, right? Because I actually didn't say up front, sure, she did have compensated alcohol cirrhosis that increased the risk of infection, sure, but like she really didn't have any of those kind of classic risk factors otherwise for an infection. And I very much felt like I was searching for a reason for her to have it if I didn't have that incidental finding from the scan, right? So I was starting to question, was it truly infection? So let me tell you what happened. So my super, super smart attending, Dr. Emily Wang, who I don't know if you worked with at Yale at all, but she was brilliant. And she was the one who pieced it together. We bumped into each other in the hallway, and she was like, is this not osteomalacia? And then when she said that out loud, I was like, oh my gosh, it's just like an illness script we don't talk about at all. Because in this day and age, with vitamin D supplements over the counter, we just don't see it because people have supplements, and it's not typically an issue where our stores are high enough to where you don't see this disease. But this was a classic presentation of osteomalacia with diffusely dystrophic bones, undetectable vitamin D, tibia tenderness on palpation. She had very vague like body aches and pains, but really when he palpated on her tibia, it caused pain. So for her, this was basically related to her Roux-en-Y gastric bypass.
That makes a lot of sense.
And again, like the information was like available in the chart. It just wasn't at the forefront. Like we had to dig and kind of find those. But when you piece that all together, like multiple like nutrient deficiencies, it all made sense. Like she's the perfect person to have that. So were we confident enough with that information to withhold the biopsy of this potential osteo lesion? Sadly not. We did get the tissue. And as you predicted, I think basically you just couldn't really justify this until you figured it out more. It grew nothing, and it just showed evidence of metabolic bone disease. So before going back to the AKI, this basically brings up the topic of radiographic mimickers of osteomyelitis, which we don't really talk about too much. But given osteo is a frequent concern prompting medicine admissions, I thought it was worth sharing. So it turns out they're like very well described non-infectious mimickers of OM. This includes degenerative spine disease, trauma, primary bone tumors and METs, which you mentioned, vasculopathies of the vessels feeding the bone, like in Raynaud's, apparently that can happen, like in the fingers, if you were to MRI the fingers. Neuropathy of complex regional pain syndrome. I actually did see that on the room service at Yale. And it's still it's an impressive list. I still need to read more into, and I'll definitely put it up on the website. But shout out to our favorite ID fellow, Brandon Lee, who basically sent me the amazing review on this topic because I had so many questions for him after this case. So, okay. This is the final stretch, and I'll say right up front here, I had no idea if there was a way to tie in basically this picture of like malabsorption, undetectable vitamin D, hypocalcemia, this whole side of things with the AKI, because I was in your headspace. I was like, this patient, she tells me No, I was like feeling pretty good. And from the son's observation, he didn't notice her like eating less or anything like this. So like, why did she have such a profound AKI? And I was wondering, could this at all be related to these like severe kind of like endocrine issues? And I got nothing. I got help from the CP solvers who gave me one very good hypothesis that I'll teach you more about, and they taught me a ton about. But anything that comes to mind, and then I'll give you the final information how this case concluded.
I think I'm going to give me 10 seconds of just good thinking, and then I'm sure I'll come back with nothing to show for it. But let me have 10 seconds here to think in silence. Yeah, I mean, I nothing that would fit the profile of the like her findings, right? Like you could have really bad hypocalcemia that gives you really bad rhabdo that then gives you AKI, but that's not her.
That's actually that's a good one. Hypocalcemic seizures causing rhabdo. That's a pretty good one. I didn't have that one. That's gonna add onto the list for sure.
I don't know that I have a can.
I didn't either.
Yeah, I don't think I got anything for you other than that. I mean, I don't know if hypo. I mean, that is I've never seen an undetectable vitamin D, so I don't know if just that degree.
I found like one paper that tried to tie together like, is it a chicken or the egg, AKI and vitamin D. It was really bizarre. I did not buy into it, and also I don't think so.
Okay.
But I was in the same headspace, and I guess just thinking like big picture about the patient's AKI, like not a clear pre-renal story. We ruled out post-renal, and then when like the glomerular workup is negative, that really just like leaves you with like the tubules and the interstitium, and you can think of kind of all the things that can happen in terms of subcategories that can cause tubular damage and interstitial processes. So we already commented like this patient could totally just have ATN, right? From just being sick initially. Maybe she downplayed her initial story, and this is just ATN from basically just lack of a good history. But then the other thing is interstitial causes too, and you already entertained like exposures for interstitial nephritis. The other category you can think of, like other than infections, a couple other things are crystal-induced diseases that can touch the tubules and the interstitium, and that would be something you would miss on a UA. So like UA negative causes of AKI. So this is where I learned a lot from my friends at the CP solvers. At least 3 of them in our group chat mentioned this. So basically, in a patient with a malabsorption history, particularly Roux-en-Y, you can consider this condition called oxalosis. This is a crystalline-induced kidney disease that's related to calcium oxalate deposition, and this can actually cause acute tubular injury and interstitial nephritis on pathology. And it presents as AKI on CKD in 60% or with AKI in 40%. And the most common underlying malabsorptive causes for oxalosis are gastric bypasses and chronic pancreatitis. So I was getting super excited at this point. I thought that they got this in the bag. We sent a serum oxalate level. It was high at 6 micromoles per liter. Upper limit is 2. But this was much, much lower than serum levels published in confirmed cases of oxalosis. So much less impressive, despite my initial excitement. And then unrelated to my zebra chase for this, after receiving all that information, nephrology wanted a kidney biopsy, given lack of clarity for really this AKI and CKD for the exact same reasons you said. And the path showed both chronic and acute findings. So for the chronic findings, she had sclerotic glomeruli suggestive of FSGS. For acute disease, there was diffuse tubular injury and acute interstitial nephritis, which was still of unclear origin because we didn't have a history of med changes or supplements that were new. There were no crystals visualized, and this essentially ruled out oxalosis because crystals are visualized in all reports of oxalosis that we could find when we were looking into the literature on this. So given her remarkable renal function improvements after the aggressive IV fluids, it seems she simply suffered an ATN on a chronic picture of FSGS. of which the culprit was maybe pre-renal related to a brewing pneumonia, but really wasn't crystal clear. Something else we considered was collapsing FSGS. It's something you can remember from like step 1 days. This is one of the ways nephrotic syndrome can present with AKI. Because remember, AKI as a presentation of nephrotic syndrome is really unusual classically, but collapsing FSGS didn't really fit this patient's picture because she didn't have profound proteinuria and she didn't have the true nephrotic syndrome. And this is what you see in FSGS. And she also got better with fluids and she wasn't immunosuppressed, which would be the treatment for collapsing FSGS. So, while she didn't have that, she did acquire this new diagnosis of FSGS. And given how common that pathologic lesion is for end-stage kidney disease patients, I definitely encourage our listeners to read about it more. I certainly had to do a ton of reading about this after this case. It was the first time I'd really seen it on initial presentation. I've had a lot of patients with it in their chart history, but I've never seen it up front. So I'll, on our website, drop a link to actually a CP Solver Schema episode where I just discussed our approach to FSGS endpoint diagnosis, and hopefully you all enjoy. But Mike, thanks for taking on this chaotic, haphazard case with, what was it, 1,100, that's the ALK-Phos, but 1,100 abnormal findings you had to interpret. It was a super fun case, though. I thought it brought up a lot of teaching points that were totally disparate in like their topics, but then trying to tie it all together was very challenging. Ultimately, it didn't play out, but we tried to be parsimonious, and we learned a lot from it.
Yeah, osteomalacia. I've never seen it, and so it wasn't even there. But yeah, obviously a classic consequence of just prolonged severe vitamin D deficiency. I bet like every second and third year med student listening is like, of course, osteomalacia. But yeah, so a great learning. I will say, just in terms of vitamin D deficiency, that is one of the causes of an isolated ALK-Phos. So, that fits. Osteomalacia, of course. And you get this really, you get the secondary hyperparathyroidism, which is probably why the PTH was so high. But then you're going to get, you get a calcium deficiency essentially. So you get a high PTH without a hypercalcemia. So yeah, no, it's fascinating. It's a good case. And the only other thing I'll say is that I learned this in clinic in residency. I saw a patient who had really, really low vitamin D. We didn't know it at the time. They got a couple of vaccines together. I think they got 3. They got flu, Tdap, and COVID, maybe. I may be mixing them. Maybe it was zoster instead of Tdap. Anyway, they got 3 vaccines in one visit, and then developed this horrible Stevens-Johnson syndrome.
Oh my gosh.
And obviously, then you have to figure out which of these vaccines is the culprit, because you can't just never give someone a flu shot or a COVID shot ever again, or, you'd like to not do that. So we reached out to Allergy Immunology, and they asked us to check a vitamin D level, and I think it was 4, so it wasn't undetectable, but it was really low. And they actually said that that's the culprit. They said the vitamin D being so low, you just have profound immune dysregulation.
Wow.
And you can get these kind of bizarre reactions. Basically, they said, like, don't retest until you get the vitamin D above normal, and then you can go back and you can retest. But until you, basically, it's like until you've repleted the vitamin D, you really have to blame it on that, and then you can go back and look for other causes. But I imagine that's maybe why she was so sick in such a weird way. Maybe it's just she was really immunocompromised in a way from the degree of her vitamin D deficiency. I don't think we think about that, because oftentimes we don't see vitamin D in that severe range. But according to Allergy Immunology, it is important for immune regulation. And when it's really, really severe like that, like less than 10, certainly undetectable, then you actually you kind of are immunocompromised, interestingly enough. So
super fascinating. Yeah, it's crazy. Just like one severe derangement can cause all of these downstream consequences, like alk phos 1100s and climbing, like refractory hypocalcemia. Like we could have given her all the calcium we wanted to. We were when she got to the floor, but then when endocrine saw her, they're like, oh no, like you need to give her super high doses of vitamin D, otherwise it's not gonna go anywhere. We have to give her these very high doses for a long time. So it was really fascinating.
And I think it's a great example of just like the Roux-en-Y, we don't see it. We see it all the time, but like the surgeons would probably recognize this quickly because they're used to seeing these patients long-term after Roux-en-Y. And classic, I mean, vitamin deficiencies after Roux-en-Y is like the name of the game, right? You have to be on vitamins for the rest of your life for exactly this reason. So I wonder if you had a surgical attending resident, especially one who did bariatric surgery often and then saw these patients post-op, or an obesity medicine doctor, right? I wonder if they would have kind of gone right there, right? Because it's just kind of, you have to blame it on that until nothing else. Her physiology is totally different than someone without a Roux-en-Y. She really does need a lot of vitamins, and she, so yeah, it was a good case of, again, something classic that probably presented relatively classically and still
very
wasn't even in my brain.
No, very, very rare, very rare. It was when it came in front of me in the form of Dr. Ellie Wag presenting it to me on a platter. I was like, duh, this has to be it. No, I'm just glad I forgot to write down that teaching point. I'm glad you mentioned about the nutrient deficiencies because, yeah, I mean, I'm a meme now with these nutrient panels. If anybody has any sort of gastric bypass procedure, anything where I'm concerned, I just send the full workup now because I've caught so many nutrient deficiencies, which will cause, and not just osteomalacia, but like vision loss. I've seen that in a patient with cirrhosis. What else have I seen recently? I'm drawing on a blank here. I mean, we already talked about B12 the other day. Yeah, all these nutrient deficiencies, they add up quickly. So I send all of them now if I have any concern. And yeah, thanks again for playing along, Mike.
Yeah, that was great. I appreciate you picking my brain and stumping me. It was good.
I'll see you next time.
See ya. This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.